going on, everybody? Welcome back to the Core Consult RX podcast. I'm mcorvino, Cswanson here as well. And we got two guests with us today. We got AJ Alford coming back for his second episode. AJ, what's good?
Hey.
That deep voice, man. He's going to put us all out of a job. And we also got fourth-year pharmacy student who has the unfortunate pleasure of being stuck on rotation with me all month. So, of course, she's already on the podcast. Ms. Lauren DuBose. Lauren, what's up?
Hi, everybody.
How's it going? It's just awesome to be finally behind the scenes.
Yeah, it's
After
really cool.
just years and years of
You can see
anticipation.
how the sausage
I know, I've
is
been
made.
waiting for this my whole life.
I know. I felt like that. I figured you were going to feel like that. So
You autographed a picture of yourself for her earlier.
I did.
Yep,
Great.
yep,
Now you
exactly. I'm going to
ruined
treasure it.
You ruined my surprise, but that's cool. Lauren, tell us about yourself. What you been doing while you're in pharmacy school? How kind of rotations? What's the plan going forward?
Oh, gosh. So...
Take it away.
Oh, gosh. Okay, so so far I've had, COVID happened, so had some interruptions there, but we were able to work through that. So I've had some good rotations, and I mean, a lot of them have been absolutely wonderful. I've done AmCare, I've done, dabbled in some industry and drug info, and in November, my last rotation was in the neuro ICU, so that was a really awesome experience. And then I've had some gen med experience too. So later, after this rotation, then I'll be in the CV ICU and then doing my hospital rotation after that. So, but yeah, so
fun stuff.
Yeah.
I'm excited. So
Do you like the critical care side of things?
I do. I do enjoy inpatient, but I really think that I want to do AmCare. So I applied for residency in December. So that's the idea. So hopefully either work outpatient, either in like a primary care or specialty clinic, and like an academic medical center or a VA.
And we've talked a little bit off the air, obviously, but about you kind of have an interest in teaching a little bit too.
Yes.
Have you gotten the opportunity to like do any of that, or like what kind of makes that interesting for you?
I don't know. I just really like those light bulb moments whenever you're able to teach people. I mean, I did a lot in undergrad too, just like tutoring and doing TA stuff. And so that's just kind of been, I think, a common thread through a lot of the things I've done, even like through high school up to now. So I just really enjoyed that mentorship experience. And so I'm hoping to be able to continue that into residency. So
That's cool. Yeah, I think when you're doing like an academic type, like MUSC, for example, if you're teaching there and then also working in the clinic, that's a pretty cool like mix, I feel like.
Yeah.
'Cause I get bored sometimes with the same old, so I get into like teach some and jump into clinic, and that's pretty cool.
yeah, I really like the ability to teach both like students and then also other healthcare providers too, and just kind of really demonstrate our value to them and, kind of see why we're an essential part of the team.
Yeah.
The easiest way to do that is not really to get a job in that field. It's just to start your own podcast and start talking. And,
It is. It's
and then
actually
people,
way easier.
See who shows up.
People just listen.
Yeah.
And then you trick people into listening to you, and then here you are.
That's what happens when you can't get a teaching job.
120 something episodes later. Whatever. No, that's cool. AJ, you back in school?
Unfortunately.
Hey.
Unfortunately, I love it.
Yeah.
Unfortunately.
I got to brag on AJ a little bit because he's been definitely trying to learn a lot of the different sides of AmCare and whatnot. And he's only in his first year of pharmacy school. So I'll show up to work and like AJ's sitting in the office already there. I'm like, oh man, you working today? Nope, just here. I was like, all right. I like it.
Social life. None at all. No friends.
None of us
We're
have it
your
either.
friends now.
Yeah, AJ, you're one of us now.
The
It's
best
fine.
pharmacists have no social life.
It's true. Unfortunately, your social life is on through the podcast and social media.
Exactly.
So I would actually argue that we have more of a social life than any of you people listening. I'm just kidding. That's false. But AJ, man, how's it be like P1 year? Is the stuff getting a little bit more interesting now that you're starting to get in the swing of things?
Not necessarily interesting, but relevant. Enjoying it. I mean, it's more and more and more, and the more I get, the more I understand, the more you can learn, kind of thing. So it's.
I can tell just from the short time I've known AJ that he's really not going to like love school until fourth year because I can just I see, unfortunately, for AJ, a lot of myself in him, where he's going to sit in class and go, "Are you kidding me?"
I can't say, I don't know that I would ever use the word love in reference to school, but yeah, fourth year is definitely my favorite, I would say.
Yeah, I mean, I genuinely feel like I like. I mean, there's moments where I didn't, obviously,
Yeah.
but for the most part, I mean, I felt like I was actually doing something.
Yeah.
I think is where I'm getting, and that's when I had all my I had 0 light bulb moments during didactic, and then
Zero.
I literally was like, "What are we doing?" And I didn't even have a pandemic to deal with.
It was a candle. You couldn't even light it.
I
Not
was
even a light
like,
bulb.
I had 2 candles, no light, and I was just trying to make them start a fire.
You were rubbing a candle on a light bulb.
It was a nightmare.
And nothing was happening.
And so fourth year for me was this like light bulb moment after I was like, that's what they were talking about. Got it. Because I'm a very kinetic learner. So if I'm not in that environment, it's a disaster. I'd be like, why is this guy eating Subway next to me? This is ridiculous. And that's all I'd be focused on for the whole hour.
Onions, God.
Oh, look at that
man.
sandwich. What a noob.
You're talking about pharmacotherapy and all you can think of is
I'm
onions.
just staring at a sandwich next to me. It was a nightmare. But yeah, so that's cool, AJ. I guarantee though, as time goes on, the pharmacotherapy stuff starts happening. It does get better. It gets a little more interesting.
Oh, yeah.
I feel like.
Yeah, it's
But-
exciting whenever you start learning stuff and being able to like apply it in lab and be able to, you know, get those good grades and be like, yeah, I kind of know some things and like you know more than you think you do. That's the biggest thing. Is like I always feel like I know nothing, but then whenever somebody asks me a question, I'm like, oh yeah, I actually do kind of know the answer to that. So
See, I have the opposite situation.
I always am like, I get something wrong. I'm like, you moron. You don't deserve a farm.
oh, trust me, I have plenty of those moments too. Don't get me wrong.
I feel like I'm getting more of those moments as time goes on. It's unbelievable. AJ, am I allowed to say like what we had talked about the other day at work? And cool.
Sure.
So Cole and I have always joked about this fake person that helped produce our podcast. And Steve, yeah, that was his name for a while. We had a couple other ones too.
Is that the skeleton back there?
Yeah.
Basically.
That's
yeah,
Steve.
basically.
That's what happened to him when he stopped showing up for the podcast.
Yep, he just
Ouch.
withered away to nothing. But so AJ and I have talked, and he's gonna be jumping on board with us, and kind of gonna be running because our hope is to have multiple camera angles and all this different stuff, so we can go live on all the different social media platforms and answer questions in real time, hopefully, and all that stuff. And then so it's just been hard while we're trying to talk and like look through our stuff we've prepped or whatever or not prepped, and to also be running cameras and stuff like that. So AJ is going to be helping us, and I'm beyond excited about that because it's going to be awesome.
Great.
Because I feel like this podcast is just in a period of stasis
Is that how
as
you
far
feel?
as not having new updates and cool new
Mike
gimmicks.
just wants a bunch of cameras and a bunch of camera angles.
I just want a lot of stuff
He just
happening.
wants a lot
I want a
of
whole
things.
production, and I want it now.
And he runs out of hands. And
I
so,
do.
Yeah, this is great.
So yeah, I'm pumped. So I'm looking forward to that, AJ. And now it's on the record. She can't back out now. It's too late.
Nothing you can do. Verbal contract.
So what are we talking about today, y'all?
We were talking about IBS.
Whoop, whoop. We haven't done one of these in, 2018?
So
Cole,
yeah,
last one?
it hasn't been 3 years, but it's been 3 different years since we did it. So it's probably been long enough.
Close enough. Oh, yeah. I keep forgetting it's 2021.
2021.
Ugh.
Yeah.
And, new
Off to-
guidelines, so here we go.
Yeah. So for those of you who have not seen it, there is brand new guidelines. I believe this is like the first like official IBS guidelines from the American College of Gastroenterology. They were published in December 2020, so pretty new. We're about 3 weeks late on the podcast episode, so we're trying to get them like immediately out so that we look cool. But
Talking about when the guidelines come out?
yeah, so we
Yeah.
were usually right on it, but we waited 3 whole weeks this time.
Well, for all anybody knows, we recorded this 3 weeks ago.
In fact, we did. This is actually December 20th right now.
Yeah, don't out yourself, guy.
Okay,
We
too
should
late.
say IBS, irritable bowel syndrome.
Yes,
IBS.
Yes.
that's what IBS stands for.
It is. Just making sure everybody's on the same page.
Hey, I hear
Imagine if you go through the whole podcast not knowing what IBS stands for.
It'd be embarrassing.
It would not be helpful, that's for sure.
It's certainly not. So, I'm going to put IBS in the title though. So hopefully they at least look at the title of the episode, and then
You're
we're
gonna
good
be
from
like,
there.
Ibs?
Ibs, what is
I'm not
this?
gonna listen to
What's
that
that?
Scoop. So we're going to kind of just talk through some of the recommendations from the guidelines. We won't go too nitty gritty into the weeds as far as the different studies and stuff like that, just because there's a lot. But we'll just touch base on what the guideline recommendations are, kind of how they separate between IBS with primarily diarrhea versus primarily constipation or mixed and all that, and then obviously go through the pharmacotherapy stuff and hopefully give a decent review, and then we'll encourage you to read the real guidelines as we always do.
Or at least the summary.
Yeah, sure. Summary's good too.
They don't really have a good summary.
Yeah, they
on
don't
this
really
one, though.
have one. It's
So they
just the full
make
thing.
you read the whole. Well, there's that one thing on page like 3 that has like the
Yeah, all
Oh, yeah,
the
this
recommendations
thing.
laid out.
but not an executive summary.
And I will say, this is 28 pages long. That's the shortest guideline I've ever read in my
I know.
life.
Yeah.
The blood pressure one was, what, 400 pages?
Yeah.
I was like, I got to page 6, and I was like, listen, I need the cliff notes.
Good that you got to page 6.
Yeah.
We got to start somewhere.
Yeah, you sure do. But, all right, so speaking of that, where do you guys want to kind of start? Should we just kind of talk through, like, some of the diagnostic criteria?
Yeah,
Yeah.
sure. Why not?
So as far as IBS goes, they have what's called the Rome 4 diagnostic criteria. And it's a combination of a few different things. Basically, they say that in order to reach that diagnosis, the patient has to have recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with, as well as being associated with 2 or more of the following criteria. And here they are. Number 1, related to defecation, so pain related to defecation, or pain associated with a change in the frequency of stool, or associated with a change in the form, and in parentheses they have appearance of stool. And we'll get to why the appearance is key here in just a minute. These criteria should be fulfilled for the last 3 months with from symptom onset, and at least 6 months before diagnosis. So it's obviously, you can't just go to Taco Bell one time, have one of those delicious party packs that they have, which is like way too many soft tacos, and then you have IBS. Obviously, that's Taco Bell induced. But
There's nothing better than those party packs.
they're
though.
so delicious.
And it's
they're
like
so bad for you.
$13. I mean,
Oh, it's a
come on.
steal.
I
You'd
guarantee-
be
Steal.
a maniac not to buy
It's
it.
highway robbery.
They
You're
taste way
losing-
better at 2 a.m. than they usually do.
Yeah.
So.
If you don't buy it, you're losing money.
And also just experience. Life experience is gained by eating
What
whatever that
was
is.
the documentary say about the Taco Bell meat, like the pink slime or whatever?
It's like 20% actual meat. The rest of it's like
Yeah.
fillers and pluff.
We don't worry about it.
Pluff mud.
Oh my gosh.
So there's meat.
Oh, there's
Exactly. That's why I'm
See,
here.
that's why I like AJ. He's more of a half full kind of guy. He's like, listen, there's meat in this. Now, yes, is there clay? For sure.
Probably,
But you're
yeah.
getting full, and that's better than some people.
Yeah, with the
And
half
you're
full,
not
half
hungry.
empty analogy, I just say it depends on whether you're filling it up or you're drinking it.
There you go.
You know.
And Baja Blast, most likely, if you're at Taco Bell.
Exactly.
Oh, geez. I promise we do diabetic education for a living. So a couple things that we'll talk about the consistency of the stool and whatnot in just a second, which is Cole's favorite part. So I'll let him talk about that. But a couple of the recommendations that they did talk about was one of them being if a patient is presenting with IBS and specifically predominantly diarrhea symptoms, then they actually recommend serologic testing to rule out celiac disease. So making sure that they don't have some kind of like gluten intolerance is what kind of leading to that. Because obviously that's not true IBS. They can go on a gluten-free diet and hopefully get better. But something to keep in mind there.
And frequently in the past, it would be kind of a diagnosis of exclusion, right? That if they couldn't figure out what it was, and they could relate it to gluten in some way, celiac disease.
So Lauren, we were talking earlier about the whole process, like the way that they go about the diagnosis part of that. Can you repeat what you were saying earlier?
So what the guidelines are recommending now is that they're recommending taking a more positive approach towards diagnosis. So the guidelines are now saying that this helps improve, time to treatment, and then also cost effectiveness, because that way you're not wasting a lot of money and the patient's time in all these diagnostic testings and just try to rule out everything but IBS.
So when you say positive, are you talking like the gastroenterologist is like, listen, you're probably going to be good, like more of a positive approach that way, or?
Yeah, well, it's taking more of an active approach and really kind of trying to, again, use those serologic testing. And they're also recommending that you use some lab values too. So normally in the past, they've used ESR, or the erythrocyte sedimentation rate, or CRP, which is C-reactive protein. Just to exclude inflammatory bowel disease in patients that have IBS-D, but they're pretty non-specific. So now they're actually recommending that there are 2 fecal-derived markers of intestinal inflammation. So there's fecal lactoferrin and then fecal calprotectin. So both of these are actually pretty sensitive and specific up until like the 90s. and their rapid test as well. So they're also saying that CRP can like still have the highest utility for distinguishing IBD from IBS. So they're also recommending that you use CRP too.
So that's to rule out IBD.
Yeah.
Correct.
IBS.
So they're looking for inflammation throughout the, and then they also mentioned something about colonoscopies you were telling me about too.
Oh, yeah. So if a patient presents and they are under 45 with IBS symptoms and they don't have any of those warning signs, which can be like hematochezia, melena, unintentional weight loss, onset of symptoms of like an older age, if they have a family history of inflammatory bowel disease or colon cancer, they're actually recommending against getting colonoscopies in those patients because it's just kind of unnecessary procedures at that point. I mean, they did mention that if a patient is 50 or older and, you're suspecting IBS in them, to go ahead and give them that colonoscopy, but not based off of their IBS potential symptoms, but just based off of their age.
Yeah. And then the other thing is they also recommend against routine stool testing for enteric pathogens. So you're not necessarily looking for a causative bacterial agent leading to it. So, and kind of going back to what Lauren was saying earlier, as far as like a positive diagnostic strategy, they're basically saying that, okay, if the patient has IBS and then, you're using these other tests and whatnot to kind of exclude other things, because basically they're trying to improve that time to initiate appropriate therapy instead of just like, well, let's just put you on, something over the counter for a little while, see if that helps, and then come back in 3 months. And, it's trying to get them on the appropriate medications kind of quickly. And then that way, hopefully the patient can get back to normal life.
Yeah. They also mentioned a really cool study from Australia. It was kind of like a language analysis, and they were encouraging providers to pretty much use, or instead of using like, oh, this patient might be suffering from IBS, or this may fit the picture of so-and-so, like they're recommending, to use like, okay, this patient is suffering from IBS, they are diagnosed with so and so much and so forth. So that actually, by providers using that type of language, that more confirmatory language, it led to more testing and better outcomes.
And they want you to be specific about the subtypes too. So IBS diarrhea, IBS constipation, or mixed. And it does matter, and you always would think, diarrhea, constipation, you know it when you see it. But there's,
You just know it when you see it.
There can be some gray area. So they actually have 7 different types of stool, or at least the appearance of stool, that can help determine whether it's IBS with constipation or IBS with diarrhea. So obviously IBS with constipation, the stool is going to be more dry, and in general, you might know what that looks like. They have type 1, which is stool with separate hard lumps like nuts. I think it looks a little more like rabbit droppings, if I had to describe it. Type 2 is sausage-shaped but lumpy, so I would probably say Babe Ruth bar with that one. Type 3 is like a sausage but with cracks on its surface.
I feel like it's more of a corn on the cob type situation.
That I think
with large kernels.
I think that's reasonable.
Okay, thank you.
And then you get into the more IBS diarrhea. So it's going to be a little more liquidy, and it's going to be, it's just going to have the appearance of having more water or more liquid. So type 4 is like a sausage or snake.
That's verbatim from the guidelines.
I'm reading this. I'm not making this up. Okay, like a sausage or snake, smooth and soft. Type 5, soft blobs with clear-cut edges. Type 6, fluffy pieces with ragged edges. A mushy stool, as they say. I'd probably say scrambled eggs. And type 7...
maple syrup.
Right, exactly. Just like Mike said, watery, no solid pieces, probably maple syrup.
Just liquid water.
But not Canadian, because Canadian's very thin. I think it's...
well, it might be more of a Canadian
It might be more of
consistency.
Canadian.
It's hard to say. That might be a type 8.
So, though comical, actually important for diagnosis.
So get your hands in there and feel out how dense it is. Is that not what you do?
I guess that's what you do. You could just ask the patient to describe it, but sure, if you want to stick your hands in and
listen,
feel
I'm more of a, I take a hands-on approach.
Okay. That's the best way to approach therapy.
Yeah, no.
So we probably should have mentioned you may not want to be eating
Yeah.
during this podcast.
Yeah. But really, we described a lot of different food groups, so you might just be hungry.
Maybe now you're hungry,
Yeah.
and you don't even know why.
You're welcome.
Well, now you do.
You're welcome. Look at Lauren. I love it. She's in it. She's a permanent member of the podcast now already. So as far as, by looking at those types, the reason for that, like Cole said, is because they want you to really categorize that subtype. And they actually mention that if you're going to have, a diagnosis of IBS, they want you to have a hyphen and then another letter after it. So IBS with constipation, or Ibsc, means that greater than 20% of the bowel movements associated with basically type 1, type 2 of that Bristol stool form scale that Cole's talking about, or 6 or 7% occurring less than 25%. So basically just more on that constipation side, which makes sense. And the flip side is true. It's if they're 25% or greater than 25% of their bowel movements are associated with that type 6, type 7, maple syrup, then you're going to have IBS-D or IBS diarrhea. And there's also a mix of that. So there's IBS mixed and there's IBS-U, which is basically you just can't determine.
Uncategorized.
Yeah. And the reason for that obviously is, again, because they want patients to get on the appropriate therapy as quickly as possible so that we're not, messing around and trying a bunch of different stuff.
So Mike would always say IBS-U if he couldn't literally touch the stool with his hands.
Exactly. I do it all the time.
Okay. I did also want to mention that what I was reading off there is called the Bristol Stool Form Scale, apparently copyright 2000. So oldie but a goodie.
It is founded by the Rome Foundation.
Yeah. So if you want to check it out, Bristol Stool Form Scale.
Boom. Yeah. They also do not recommend testing for food allergies unless, specifically you have, can kind of isolate what the allergy is. Then maybe go ahead and get a test. But they don't want you just randomly testing for food allergies. I guess because the delay of care and it can be hard to still distinguish even after testing and whatnot. So they recommend against that, and just to kind of go ahead and start treating and see what happens.
And they don't address elimination diets or anything in this, right? They don't make any recommendations either way. From
So as far as diets, what they mostly spend time with was talking about the Fodmaps diet, because that's kind of been shown to basically if you can limit some of the FODMAPs in your diet, then you can limit some of the side effects.
Right.
So for those of you who are not familiar with FODMAPs, it's a mnemonic. And so basically F is fermentable, O is the oligosaccharides. So things like wheat, barley, rye, peas, cashews, legumes, lentils, chickpeas, basically all of the disgusting foods. You can't have those, so that's good news. D is disaccharides. So, for instance, like lactose, so things that are dairy, milk, yogurt, ice cream, custard. Who eats custard?
They have that Italian ice place, and they'll have frozen custards. Those are interesting.
You ever had creme brulee?
Okay, all right.
That's way too fancy for me.
Yeah, I'm saying, if I can't spell it, I don't eat it. That's a rule of my life, and I stick to it. M is for monosaccharides, so free fructose, or fructose in excess of glucose, to be specific. So some of the fruits that are pretty common can have a lot of high fructose levels, so apples, pears, mangoes, cherries, watermelons, and then asparagus, believe it or not. And then A just stands for and. So that's easy. That's an easy one to remember.
Yep, that's easy.
P is polyols, so sorbitol, mannitol, xylitol, which is toxic to dogs, by the way, in case you guys are thinking about getting into veterinary medicine. I don't know why I remember that. Just something popped in my head. That's a true fact, though. I'm almost 90% sure.
Don't give your pet xylitol.
Yeah, so there you go.
And they're all like, what is that?
It's a sweetener. It's a polyol. I just said it.
That's all you need to know.
Yeah, just look it up. It's on Wikipedia probably. But those can be in things like different fruits like we already mentioned, but also in things like mushrooms and cauliflower, artificially sweetened chewing gum. I'm sure it's probably got to be some in this Monster can I'm drinking, I would guess. Probably.
Surely. Everything's in there.
Sorbitol, mannitol, and all that stuff. Yeah, sure. There is a lot of stuff in here, a lot of nutrients, Cole. Yes. That's why I stay so healthy all the time.
At least it's sugar-free. I would take unless I had IBS, apparently, I would take the artificial sweeteners over the sugar. Yeah. I'm
so addicted to Monster that I feel like even if I was, no disrespect to people who are actually suffering from IBS, but I do feel like that every morning I have this dilemma of like,
Is it worth it?
Is it worth it? And I feel like I would be.
I
like,
have the
there's
same
some
issue with
mornings
China.
that I would give in.
I have the same issue with Chinese food. I always side on the Chinese food side.
It's delicious.
But
you've
you've changed your tune because a year ago or so, you wanted to prove that you weren't addicted, so you just didn't drink them for like a couple weeks or something like that. And you're like, oh, I'm fine, and then you just
splitting
kept going.
migraines, didn't care. I was like, I'm winning this bet. I'm like, there's no way I'm gonna go down. I'm dying on my sword. So yeah, they're like, you feel fine? I was like, fine. My head's throbbing. I didn't tell anybody. I was like, dude, I literally have never felt better just stopping cold turkey.
Oh my God.
That's a nightmare. I had to go home and get an IV Monster that night. All right, so I guess let's jump into some of the actual treatments. Like, so once you've distinguished between, whether the subtypes and all that stuff, and you say, okay, the person this has IBS. We got to talk about the pharmacotherapy. And actually, real quick, I do want to mention too, the other thing to consider is the psychopathology of IBS. It's something I don't know if the guidelines mentioned. I don't know if you saw anything in there, Lauren.
No.
But there's actually a lot of studies and whatnot, and they've already been completed, and also that are being looked at where they're looking at the gut biome, its correlation to mood and, whether it's depression or other behavioral health issues, and how one can lead to the other and vice versa. And there's a really big correlation between that. So I will say that, treating IBS, and one of the psychiatrists that I work with, physicians, has actually had a really good friend of his that in his earlier on in his career, he did a lot of research with this, and that was one of the hopes, was that if you can fix the GI issues, in some cases you can actually fix some of the psych issues, and vice versa and all that. So that the fact that there's a correlation there is pretty interesting to me.
A new frontier, right?
Yeah. So I thought that was kind of interesting. So
Yeah.
I thought I'd throw that in there. But so we'll talk through medication wise. So Lauren, what's the first med they brought up?
Well, they start talking about, just non-pharmacological stuff. just depending on how you want to categorize it. So they look at dietary fiber, and then they also mentioned, let's see.
Like probiotics.
Yeah, kind of like probiotics. They mentioned antispasmodics, which I know is pretty common in use for IBS. First off, they do recommend using soluble fibers they really kind of overall look at it as more of a global kind of treatment instead of just, treating towards like number of stools and whatnot. But I think it's just most like kind of a quality of life sort of perspective. So they're definitely recommending soluble fiber. And this is for both types. And they're actually recommending against the use of antispasmodics. Which was surprising to me. It's still conditional and low quality of evidence from what they said, but they only really mentioned dicyclamine and hyoscyamin. So,
which are used very commonly.
Yes.
Yeah. So, which I think, this is where I will say that there's guidelines for a reason. They're supposed to be guiding you to, along the way, but not necessarily something you have to, follow without deviation. Because I will say that I've seen patients that do well with, and get a lot of pain relief from things like hyoscyamin. But I think the reason why they're not putting that in the recommendations is because they don't want these patients being on this long term. Mm-hmm. There's no good evidence that shows that it's actually going to improve outcomes. It may improve like symptom relief then and there, but they're not without side effects for one. So you got all the anticholinergic side effects you got to deal with from an antispasmodic. And then, it's something that if we're masking the pain and whatnot, then maybe we're just prolonging them actually getting something that's truly going to fix some of the pathophysiology that's going on.
Right.
So I think that's where, but I would say, that recommendation, and the reason I throw that in there is because I don't want it to be something that like you see a patient on, hyoscyamin and you're like, hey, we got to stop this immediately. And, it's at least in my experience, I haven't seen like a lot of harm that comes from those necessarily, other than like the anticholinergic side effects and using them in elderly and stuff like that. You got to be careful. But from a younger patient, I've had patients that have gotten some good relief, at least in the short term. I just think it needs to be reevaluated and not just put on indefinitely. the fiber agents that they talked about, there's a study from 2011. It was a systematic review, and they were looking at kind of bulking agents. So, it's the fiber, the over-the-counter fiber agents like psyllium or like Fibercon or Citracel and some of those. And they basically found that in this meta-analysis anyway, that there was no beneficial effect for bulking agents over placebo as far as improving abdominal pain. Now, there's other studies that have shown that it can potentially help, in certain things like constipation and other things. But I think that because of the lack of evidence from a global standpoint of IBS, I think that's why their recommendations are the way they are. I mean, they'll say it's a low quality to go ahead and try it, but it's not something I would put a lot of faith in. I mean, they still recommend it, but and I would also encourage patients to get it from their diet if possible. So fiber from the diet is always going to be better than packing.
They recommend 25 to 35 grams of total fiber per day. It's a lot of fiber.
A lot of fiber.
Yeah.
The other thing about IBS symptoms that I think a lot of people start with, as far as like pharmacotherapy goes, is things like Miralax. So like our osmotic laxatives. So, and the reason being, obviously, they're over the counter. They're, easy to get access to. They're simple to use, and what they're doing is basically drawing water into the bowel lumen through osmosis, and that's going to then increase peristalsis and push everything where you want it to go. The issue with that is the effectiveness of that, especially long term, is not really seen in clinical studies. So, Lauren, do they recommend Miralax anymore?
No.
I guess we should also point out that we are talking about a diagnosis of IBS, which is considered a long-term disease state because it has to be over the course of 3 months or so.
Right.
So I guess to your point about the spasmodics, even it's an isolated incident. So the intention is for you're saying it's fine in isolated incidents, but they're saying in IBS long-term no good.
Right.
Similar to Miralax, isolated constipation, Miralax can definitely get the job done. Long-term IBS treatment, not necessarily their recommendation.
Yeah,
doesn't mean that you can't use these in constipation or the others in diarrhea.
Yeah, absolutely. And there's also different recommendations if it's like idiopathic, chronic idiopathic constipation. So IBS by itself, because again, IBS is always associated with pain. So that's the other piece of that is you're trying to find things that are going to alleviate the constipation or diarrhea to alleviate the pain ultimately.
Right.
So Miralax and those things they don't recommend anymore. But one thing I thought was real odd that kind of surprised me. What do you think I'm going to say, Laura?
Peppermint oil.
Peppermint oil. So as many times you guys have heard me just bash essential oils and whatnot on this podcast, one finds itself into the guidelines. So I stand corrected.
How the turntables
have turned. Gotta give a shout out to the office. Got to give a shout out to the office because it's gone now, and Cole's been very sad.
I know.
I'm sad.
Cole brought up in his last episode, the first thing he said, he's like, the office is gone, so that's great.
Now you just got to get Peacock.
Which one?
That's NBC streaming service.
Yeah.
Apparently it's on there.
Everyone is getting their own streaming service. I'm going to need them all to figure it out and then just...
The good news is they're like $7 a piece. The bad news is once you subscribe, you forget you subscribe. And then
once you have 10 of those... You're just paying for cable again.
Right. But
that's true.
But you have all these apps to choose from, so it looks way cooler.
It does.
And it comes through at different times in the month. So for me, I'm like, I'm paying $7 for cable. This is incredible.
But then they send
every day you're paying $7 for cable.
Yeah. It's just, if you look at it like that, it's not so bad.
Yeah. Then they send you secret emails and say, hey, we're actually going to raise our services, but you don't know.
Because your junk email, and then it all goes off the rails.
Yep.
It's a vicious situation.
I'm not talking about anybody in particular.
I have more of those stupid services than I can. I need that app that like tells you all the nonsense you subscribe to, so you can start deleting it.
See, I'm very aware of like every subscription because I log it every single month, so I know every subscription I have, and I know that I still subscribe to some useless ones, but it's hard.
Can't let them go.
I know.
I hear you because you're like that one time I'm trying to watch whatever stupid show.
Not gonna be able to
see it. It's gonna be a nightmare. So Anyways, back to IBS. So as far as like what they do recommend, so peppermint was one that they said that they could try. Did you find a couple examples of some peppermint oil extract?
I did. So a lot of them came in capsule form. The best one was Nature's Way, peppermint leaf. Comes in a little vegetarian capsule.
It's even vegan. So it's like super vegetarian.
Hey.
That's cool. Was that expensive?
Don't know.
Amazon says currently
get it.
unavailable, so it's off the
So,
market. FDA took it off the
priceless.
market. It's literally all right. AJ, the best one's off the market, not off to a good start.
Now what?
Shouldn't be too expensive though.
Yeah, it looks like they're like $5-10.
So I'm presuming that a peppermint would not have actual peppermint oil in it. If I just had to guess, it's just got peppermint flavoring.
Like
Probably-
the little star, like
the
red and white.
lifesavers.
Red and-
Star?
like they call
the
them
peppermints that you
like peppermint, like the star, like the red and
Most peppermints that
white.
I
You're talking
eat are
about
round.
You're talking about like yes, round, but they have like the star
You
pattern.
mean the lifesavers?
You know what I'm talking about?
yeah, okay, the
Yeah.
red star pattern and the
Yes.
white
Yes.
circle.
The
Okay.
Christmas mints.
I
Thank
gotcha.
you.
Yes,
Yes.
that's what I'm talking about.
Yeah,
Like
see?
sucking on a peppermint. Can that help my IBS?
Probably not.
I would say if you eat about 40 of them a day,
That's what I'm
The
saying.
guidelines at 45.
45. Never mind.
Oh,
It just
did he
says-
really?
No.
Conversion.
Oh, I was about to say. I was like, no way.
For legal
Wow.
reasons, that's a joke.
Yeah. For legal reasons, we do not want to induce diabetes on this show. So, I don't know. That's a good question. I would doubt it.
But when you say peppermint, I mean that's because that's something that people say. Peppermint to soothe your stomach.
Yeah,
Yeah.
you're right.
It's true. So there you go. Grandma was right.
Yep.
All those years, who knew? Of course, giving you ginger ale wasn't going to do it because now your sugar's high. So she's half right. But as far as the actual like approved medications that are prescription only and all that, there's a few different classes of medications we can use for IBS constipation. So the first one being what is called a chloride channel activator, as it's Amitiza. So this is something that is basically going to, again, activate chloride channels on the apical membrane of intestinal epithelial cells. That's going to cause them to increase fluid secretion and then improve that fecal transit, if you will. Now, if you're looking at IBS, it is actually approved in females only and 18 years and older. That being said, they also have it approved in chronic idiopathic constipation at a different dose for all adults. So there's plenty of males that use this off-label. I think it was just because of how they studied it initially that is kind of kept the FDA from approving it in men as well. So I'd have to go back and like really dig into the studies, but I don't think that there was a difference between males and females in the original studies, but don't quote me on that because I'd have to go back and look. But as far as, is it effective or not? That's where I would kind of be a little bit hesitant because, some people may get some relief from it. But for example, one of the main studies, it was a 12-week study. It showed an 18% overall response for when someone was giving Amitiza compared to a 10% response in placebo. And that benefit persisted and even potentially increased by the 52-week follow-up. But really the change where people got a little bit more excited was that they went back to that study when the definition of a response for IBS studies was changed. And it was so they did a post hoc analysis of the same data, and then that 18% jumped to 24%. Woo!
And for the price,
Great.
I'd be hoping for more than 24%.
Yeah.
But it's approved and it's available. The one thing is that it seems like the patients really don't start getting their relief of symptoms until after about the first month. So that's
It's also kind of wow.
Yeah. So you got to be in it for an entire month. Adverse effects, the main complaints, nausea, diarrhea. So that's great. You fix your constipation and you have diarrhea. Perfect. And headache, and then also hypokalemia. So if you have a patient that's also on diuretics for something else, whatever the case may be, you do got to really watch their potassium because you don't want to bottom their potassium out, and then you'll have a whole new set of problems.
Isn't the nausea dose dependent too?
I believe so, because there's 8 micrograms in 24.
Yeah.
And so, I believe it does obviously get worse with the higher doses. But, the diarrhea is always the one that I've personally heard more patients complain about, which makes sense. Unfortunately, all of these are going to be
Right.
kind of a side effect.
Yeah.
So you have to decide which one you like better.
Constipation or diarrhea?
Yeah.
Pick your poison.
As long as the pain goes away, though, I guess that makes it a little bit better.
Well,
And then I give them a GLP-1 on top of it, and that makes them go back to being constipated, and then metformin, and eventually it all clears up.
everything's good. You're back to regular.
You're on 17 meds.
I know. I think we need a testimonial from someone actually that has IBS.
Someone that Mike treats. So there is another class that seems to have a bit better data. So the guanolate cyclase agonists. We've talked about guanolate cyclase before, but there's Linzess and Trulance. These increase chloride and bicarbonate secretion in the intestinal lumen to help with constipation. They do have a black box warning, though, for death due to dehydration. Specifically, this was seen in animal studies, poor animals. You want to avoid these in peds, so these are for adults. Linzess needs to be dispensed in its original container, just a note for the retail pharmacists. And they do have, or at least Linzess has some recommendations for dosing. We didn't mention, but Amitiza needs to be taken with food.
Yes.
Linzess needs to be taken 30 minutes before breakfast, but on an empty stomach. Trulance, it doesn't really matter, with or without food.
Whoop, whoop.
Nice.
Way to go, Trulance. You want to talk about the studies real quick?
Yeah, so with the one Linzess study, it was comparing Linzess to placebo at the 290 microgram dose. Significant reduction in symptoms with the Linzess, with a great number needed to treat of 6, so that's what we like to see. The statistical significance of the difference was reached at the end of week 1, which is pretty fantastic. So compared to the Amitiza, to me, this has some more compelling data. Both are very expensive. One different study showed continued benefit at 6 months, which is longer than usual IBS studies go. So that's definitely a good thing. Trulance at the 3 milligram dose was compared to placebo. Significant reduction in symptoms as well. Number needed to treat of 9, which is really good. And also statistical significance was reached by the end of week 1. So they're just showing off.
And I think it was Trulance that they did their study was 6 months long as well, which is like usually they're 12-week studies for IBS, and then they just kind of monitor over time. But like they did a full 6-week and just tracked the difference with Trulance. I think it was one of the first studies that had the longest duration. The other thing is with Linzess too, because it's approved for chronic idiopathic constipation, their newest dose of that, which is not really new anymore, but the newest compared to the other two is 72 micrograms, and that's the one that and the 145 is for the CIC, and then IBS is the 290, like Cole's saying. That's just why the difference in, if you're wondering about why they only studied the higher dose. The other thing is too, Cole, what do you think our price is for Linzess at Fetter?
I don't even want to know.
For cash paying patients who don't have insurance, I have to double check myself for sure, but I think it's $5.
No way.
Yes, cash paying patients
Wow.
$5
Crazy.
for Linzess. It would be 10 at the max.
Wow.
So yeah,
That's wild.
So I was actually really excited when these guidelines came out, and one of the things that Lauren and I got to do is send a update to the providers, being like, "Yo." Because that pushes that for the pharmacy too. And we want you to use Linzess, and we got it dirt cheap.
Right.
Yep. And they are strongly recommending use of these
Yep.
over
Yes.
Amitiza.
And that's not to say they don't have side effects and shouldn't be used with caution and whatnot, but
No
over
side
Amitiza
effects.
for sure. Yes. Clean. Totally clean.
Couldn't be cleaner. Just, diarrhea. Again, same kind of thing. That's what we'd be expecting.
And, death due to dehydration, but that's neither here nor
That's
there.
only in animal studies.
Right.
Yeah.
Gosh,
Luckily, it is.
don't be so vegan.
I like the peppermint oil.
That's true. Lauren, will you talk about the new kid on the block?
Ooh, tenapanor, yes. So tenapanor is again a new medication. So the brand name is Ibsrela. I don't know where they come up with these.
IBS Rella?
Sure. Let's go with that.
Perfect.
For real?
So it's a new class of medication. So it's a sodium hydrogen exchanger 3 inhibitor. So the NHE3. So that's expressed on the luminal surface of the small intestine and the proximal colon. And so what that does is that reduces sodium absorption and increases sodium and fluid excretion in the stool. So that's how that works. So the 2 trials that they used in order to get them through the FDA, they have the Tempo 1 and Tempo 2 trial. And if you're Googling this, the E in Tempo is a 3, because I know that there are some actual Tempo
They guessed
trials
my
with
password.
an E. I know.
Great.
Gosh, dang. So yeah, both of these trials, the Tempo 2 is actually an extension of the Tempo 1. And so the first one was a 12-week trial compared to placebo, randomized, double-blind. So they kind of were looking at the efficacy of both increased spontaneous bowel movements and then also improvement in abdominal pain. And they did show a improvement of 27% versus 19%. within the first 6 weeks out of the 12 weeks. And that's in the first study. The second one, they extended it to 26 weeks, which is pretty awesome. And so then they looked at it again at 6 weeks, 9 weeks, and 13 out of 26 weeks. And so they additionally kept having more and more improvement. So at 13 out of 26 weeks, they were at 35.5% versus 24.3% overall.
Not bad.
Yeah. So, I mean, again, the same kind of thing was that the diarrhea was typically transient and kind of mild to moderate. But I was looking at the graphs in the Tempo 2 trial, and what was really interesting is that they don't really explicitly state this, but they did say that as far as like the numbers go, but they did show that improvement was observed by 1 week of initiation, and they were maintained by the end of the treatment period.
Yeah.
Good.
And then the last one that we'll mention that the guidelines actually talk about is a medication called Tegaserod, or Zelnorm is the brand name. That is a 5-HT4 agonist. Now, they say basically it is approved and suggested by them in female patients only. So Amitiza is officially like in female patients was what it was studied in, but this one is truly like only recommended in female patients younger than 65 years old, and they have to have one or less cardiovascular risk factors, and they also have to have failed an actual trial of being on one of the other medications like Trulance or Amitiza, or one of those. So the reason for all the things you have to get through in order to actually qualify for this medication is because it does have the increased risk of serious cardiovascular effects or events. So MIs, strokes, things like that. Death has been reported in patients taking this. So you just have to be really careful. And there's even been like some suicidal ideation associated with it as well.
So IBS or death.
Yeah. So that's one that we would use with extreme caution, and definitely not used in elderly females or males. The safety and efficacy has never been established, so we don't know. But yeah, that's the constipation meds for IBS.
Nice.
We want to jump into diarrhea?
Do it.
Well, we might be backpedaling a little bit. Did we talk about probiotics?
I think we did. I don't know.
I don't know that we did. I think we just mentioned them as something that was referenced, but I don't think we went in depth into them.
Give us your thoughts on probiotics.
Well, the guidelines are saying that they are suggesting against it. They're not making a huge, their language isn't really that confirmatory, but still pretty low level of evidence. So I think that they just saw from the data there wasn't really any improvement in outcome in terms of global IBS symptoms.
And previously they kind of had a statement, or at least a meta-analysis about bifidobacterium, saying that it might help alleviate some symptoms, but now they're just in general not saying that, or they pretty much have low evidence to say it does much.
Yeah. So sorry, I didn't mean to backpedal here, but
are you kidding me? We backpedal all the time.
It's all we know how to do.
Yeah, it's fine.
We don't know how to ride bikes.
You think we have a schedule?
Okay, great. I fit right in then.
Yeah, perfect. Actually doing way better than we ever do. So IBS with diarrhea. One of the recommendations that they said not to use was with the bile acid sequestrants. So like cholestyramine, things like that. They say that basically, because the thought process originally was bile acid malabsorption could be leading to the diarrhea and whatnot, but the data is not fully backing that up. And so testing for bile acid malabsorption, they say, is challenging, and so it's something that they don't recommend using those as first-line treatments, specifically in IBS. So for those of you who are really liking cholestyramine, it's out. Call, it's out.
Sorry, guys.
I don't know that there's anyone who really likes that at all.
Maybe.
I'm talking patient-wise.
Oh.
That's gross.
Yeah.
How do you know? Have you tried Call?
Smelled it.
What about the cholestyramine, though? It's orange.
Yeah,
it looks like orange juice.
packets.
It looks like it. Yeah, what do you think that stuff tastes like?
We should try it.
Orange?
I don't know.
Can't be.
I don't trust
That's
it.
what it says.
I don't trust it. Yeah, it looks like probably tastes just like disgusting orange juice.
Well,
It tastes like Tang. I bet it's more
I
of a
bet
Tang.
it is like Tang.
Remember Tang?
Yeah, I do.
What about Sunny D?
Astronaut drinks it, so it's got to be great. It's disgusting. Every kid wanted it.
No, Sunny D was my jam.
Drank some Sunny D back in the day.
Yes. A lot of it. Probably too much.
Never been a big orange juice guy.
No. Well, I used to drink it a lot when I was a kid before I realized that it was packed with sugar. I was like, oh, healthy. Orange juice.
I have that conversation almost daily with patients. They're like, what are you talking about? There's no sugar in orange juice. It's healthy. I'm getting my vitamin C. I'm keeping COVID away.
It's like the
About
exact same
that.
amount of sugar as a soda of the same amount.
Yeah. And then I use it to wash down my Raisin Bran cereal that I have. Like, oh, no.
Okay, wait, pulp or no pulp?
Oh, gosh. Pulp. If you have pulp in my orange juice, we're never speaking again.
No.
I'm a big advocate for anti-pulp drinks.
Big anti-pulper.
Yeah, I'm big. That's a good T-shirt. I'm a big anti-pulper. So what can we use for IBS with diarrhea? Difaxin. I'll go ahead and say it.
Yep, there's that.
That's one option. Though initially, we think Difaxin, we were thinking about hepatic encephalopathy, and then things like traveler's diarrhea. But IBS is definitely you're seeing it more and more used in that case. But the issue is it's very expensive.
Yeah, it's hard to get covered. You can.
Yeah, definitely
tough.
not the cheapest drug.
Yeah, especially considering it's, deductible season.
It is deductible. Yes, it is deductible season for sure. Oof. Now, one of the reasons why they do like this medication is because it's also going to help with just the overall global IBS symptoms. So not just the actual IBS diarrhea, the diarrhea piece, but also the bloating, the pain, stuff like that. It seems to reduce those as well. Adverse effects, though, we're thinking of things like peripheral edema, dizziness, headache, flatulence. Always a good side effect to have on board.
It's a great one.
Yeah. And then the cost. That's the biggest side effect. How are you going to find $8,000 or whatever it costs a month to buy it? It's
a lot of these are expensive. So there's another one, Ibsc. This one's unique in that it's a controlled substance. Reason being, it acts on opioid receptors. So it's a mixed mu opioid receptor agonist, kappa opioid receptor agonist, and it acts locally to reduce abdominal pain and diarrhea. So it is acting on diarrhea, but it's also attacking the pain component. And this is an IBSD without constipating adverse effects. So some of these might cause constipation. It seems like Ibsc doesn't so much. There are reasons that you would not be able to take this. So if you have had your gallbladder removed, can't take this. If you're an alcoholic, or if you have more than 3 alcoholic drinks per day, can't take Ibsc. Also, possible increased risk for pancreatitis and nausea, vomiting, or at least nausea, abdominal pain, upper respiratory infections, possible side effects. Take it with food.
Yeah. You said pancreatitis?
Yeah.
Okay. I always find that weird, like alcoholism. Also, if you drink greater than 3 drinks, why don't they just say that?
I know.
I feel like it's almost like, are you an alcoholic? No. Are you a minor alcoholic?
Well, maybe yeah, I guess, can you be an alcoholic and drink less than 3 drinks a day?
I find it hard to believe.
Yeah.
Otherwise, I know a lot of alcoholics.
Well, I think alcoholism is it might be a different, like,
yeah, it's more of a, because it's
psychological,
debilitating and
right, yeah.
Okay. So right. I stand corrected. All the substance abuse counselors listening, like we have so many, are like screaming at me right now. You moron.
What are you talking about?
Idiot doesn't even know the difference.
So maybe a recovering alcoholic. Would that be, I don't know. I wonder.
Maybe.
Either,
that's a good point.
I don't know.
I think one thing to keep in mind too is it is an opioid receptor agonist, so it is a controlled substance.
Yes.
So I remember when I still worked in like dispensing realm of pharmacy, I remember getting screamed at by like a 75-year-old lady because I couldn't fill her medication because it was like a week early. And she's like, this medication is for diarrhea. She's screaming this at me in front of all these other people in the lobby. And I'm just like, yep, I'm aware. I did not make the rules of the diarrhea medicine, but it is a controlled substance. So it's like one of those things. It's that people obviously know pain medicine is going to be a controlled substance. Not so much when it's the diarrhea medicine.
Well, it acts on pain.
Yeah, but no,
pain.
I agree.
That's what you should say. You should say, no, it's your pain and diarrhea medicine.
Yeah, it's your painful intestines / diarrhea.
Right.
The diarrhea you experience from pain, or pain from diarrhea rather, that's what's fixing. There you go.
There you go.
Another option, and this is again more after patients have been, tried other measures and failed and whatnot, is the Lotrinex or Alisitron, which is a 5-HT3 antagonist, and it's approved for the treatment of severe IBS with diarrhea in female patients. Again, the ladies have all the treatment options. Guys are just out of luck.
Well,
Sorry,
it's also more
guys.
common in women.
Okay, listen, Cole. I'm trying to make a stand here for men's rights.
I know I'm outnumbered here.
Oh, no, don't even bother. That's the most obnoxious comment you could ever say. It's that nonsense. So it is approved, but patients have to have had symptoms that have lasted for 6 months and they've failed all other conventional treatment options. And so the reason for that is because one of the adverse effects potentially that can be caused is ischemic colitis, because it can cause such severe constipation that it was actually removed from the U.S. market originally, and now it is available again under like restricted prescribing program. So it's a very specifically who gets this program or who gets this medication out there because they're not trying to cause ischemic colitis. That's not what you want.
I don't want that.
I definitely don't want that.
I don't want that either. I'll pass.
What about Lapyramide?
They actually don't recommend it as first-line therapy. What they say, they don't go into a lot of it, but they just say it's not recommended because for treating symptoms, because it might improve your diarrhea, but not your global symptoms. So you still could have that abdominal pain.
Do you know Lapyramide is actually something that could be potentially abused?
Can be.
Yeah.
I made a post about that one time and on Instagram, and I had someone actually reach out on Instagram and say that they were happy that I made that post because they actually had a family member that passed away from taking excessive amounts of Lapyramide. Yeah. So
Really?
if you ever,
That's
those of you in dispensing, you see a teenager that doesn't necessarily look like he has IBS, he's getting a whole bunch of Lapyramide, be like, hey man, let's talk. So yeah, apparently if you use it in high enough doses, it can cause a euphoric effect and almost got like that opioid use. And you also can get like opioid withdrawal type symptoms if you're. I've even seen it used as like a self taper for like someone coming off of opioids or heroin or something like that. They'll use Lapyramide to kind of counteract the withdrawal symptoms, and it can cause. It's not recommended to do that. But
I'm just
Right.
interested to know the first person to realize that, like this person must have had some bad diarrhea. Mm-hmm. And then it turns out they feel great.
maybe, or someone just
And then
really
they
understood chemistry and was like, "Oh, look at that chemical. That's going to definitely."
I like my idea better.
I don't know. I'm always really impressed by the people who, it's a lot of clandestine chemists that came up with a lot of our, illegal medications that people like to use. And I'm like, man.
You're impressed with all the street drugs?
Well, no, I'm just impressed that people you're smart enough to come up with it. I can't. Can you create LSD? I mean, I couldn't do that. You could leave me in this room for another 100 years and I'd be like, I got nothing. So the fact that these people can come up with that stuff, I'm like, man, if only we could have made you not do that.
Right. If only we could have pointed those smarts in a different
they're
direction.
obviously intelligent people. So
Right.
yeah, those clandestine chemists, shout out.
Dang.
All you guys out there being responsible and listening to our podcast.
Being responsible and not making crazy
We're
drugs.
not trying to make real life Breaking Bad, please
Yeah.
and thank you.
Right.
That's not real life?
What?
Oh, wait. I thought it was a documentary.
That was fake?
Oh, what? Sorry.
Don't ruin Cole's Netflix for him even more than it already has been. What else? Did we miss anything?
TCAs.
Oh, yes, that's right. Thank you, Lauren.
Yeah.
What about TCAs?
So they're actually recommending use of TCAs for improving painful conditions and also improving abdominal pain just because of their anticholinergic effects. And they can actually slow GI transit and improve symptoms of diarrhea in some patients. So they mentioned 4 of them. They studied 6, or at least looked at studies at 6 different TCAs. But the 4 that came out of the running were amitriptyline, imipramine, desipramine, and nortriptyline. So
It's interesting how far they fell out of favor for a little while with like depression, and then they're just popping back in for these random disease states that they're realizing are very central.
Yeah.
Yeah, so it's really kind of using their side effects to their advantage.
Which this is related, I guess, to how they're used in central pain disorders as well, but migraines, whatnot. It's interesting.
Oh, even in general depression, like with something we oftentimes overlook, but like nortriptyline without some of the adverse effects because being a secondary amine, it's something that is in a lot of studies now that shows that it can be helpful. I mean, STAR-D included a whole arm just to add that. So, Lauren, we were talking about the difference between the tertiary and secondary, and you were telling me that they say something about when to do like amitriptyline versus.
Well, they basically said that they weren't able to recommend one over the other.
Okay.
Just because there are no head-to-head trials, at least comparing them for treatment of IBS-related symptoms. So But they did mention a little bit, and this is also a recommendation for both forms of IBS too. I know we had talked a little bit earlier about this, but a thought that I had was that you could, since disipramine and nortriptyline are secondary amines and they have less like antihistaminic and less anticholinergic effects, you could potentially use them for IBS-C. But you could also, but since amitriptyline and imipramine, you could, since they're tertiary amines and they have more of those anticholinergic effects, you could probably use that for IBS-D patients. I mean, the guidelines, of course, don't say that, so take what I'm saying with a grain of salt.
No, but that's actually I completely agree with that. It's a very good thought because it makes sense from a side effect profile. And we see that like with depression, like you're going to have, and the reason why a lot of the depression trials use nortriptyline is because they don't have a lot of the same adverse effects and orthostatic hypotension and stuff with nortriptyline versus amitriptyline or imipramine. But if you have diarrhea as the main thing, you're going to give something with more anticholinergic effects. If not, then you want to give disipramine or nortriptyline because you'll have less of that. So I completely agree with that. We're writing our own guideline, Lauren.
Using side effects to treat.
Yeah.
What is a side effect but an
unintended?
A treatment misunderstood.
I'll use the words of one of the essential oils people that tried to sell me one time. She said the good thing about essential oils is they don't have side effects. They have side benefits. I said,
okay,
that's interesting.
That's a great way to look at it.
I could write a book named Side Benefits, but I'm going to write one called A Treatment Misunderstood, side effects.
Okay, fine.
Yeah.
There you go.
That's coming to you 2022.
That's a long title, but right on.
Gotta have the colon in there.
Would ischemic colitis be considered, like the side effect? So,
wow. Listen, the thing that wasn't on the brochure, so there's no way of knowing.
Okay, I'm sorry, I'm ruining it. So,
I did ask, and I was like, as I heard that comment, I was like, why bother? Just go home. Just keep your mouth shut. And then the other part of my brain was like, no, say something. So, of course, that part won like it always does. And I was like, oh, really? There's no side effects at all? No interactions with medication? And she's like, nope, nothing. And I said, have you ever heard of cytochrome P450 3A4 inhibition? She's like, Because, and then I went into statins and how they can interact with that. And she's like, really? She's like, we need someone like you on our team. I was like, give me a t-shirt. Let's roll. I didn't join the cult, but
oh no,
next time.
I did want to mention though, also with the TCAs, in the guidelines they say with the studies that they were looking at, the number needed to treat with TCAs was 4.5. So I thought that was interesting. I would rather go and actually dig into the actual studies, but they're mentioning that they also looked at some with different antidepressants too, and like SSRIs. But the actual beneficial effects are only because of the TCAs and not the SSRIs. So this is the only class that is going to work.
Cool. So. That's good. That's awesome.
Yeah.
I like it. Anything else? Would we miss anything?
I lied earlier whenever I said that
everything.
They didn't have any psychotherapy stuff. They do. I
gosh.
lied.
Lauren.
Sorry. I'm sorry.
She didn't get to the end of the guidelines.
Hey, I'm going on record and I'm correcting myself. So
it's quicker than we normally correct ourselves. We usually do it 4 episodes later.
Do we ever correct ourselves?
I
have before.
Hey, remember that thing we said like 18 episodes ago? Yeah, that was wrong. We looked it up. We finally looked it up. So make sure you check out the guidelines. They were published a couple weeks ago. It's a free download. You don't have to be. I believe it's free. I don't think I was plugged into MUSC when I did it. And but yeah, make sure you check that out. Good stuff. And then let us know what you think in the comments and all that cool stuff. Or send us an email if you want to talk to us that way. But thank you guys so much for listening. I greatly appreciate it. Thanks again for the Patreon subscribers. That's been awesome. I hope that content is helping you guys out. And if you have any other questions, concerns, comments, whatever, definitely reach out to us. Talk to you soon. Have a great night. See ya.
Bye.